First of all, I would like to acknowledge the support and the contributions of many of my colleagues and collaborators who have helped to move this project forward. In particular, Pascal Carrion and the Center for Quality and Productivity Improvement. And I'd like to thank John Beasley and many of the participants of the inaugural and the second iPractice conferences. Those were both very, very instrumental in helping me to formalize research ideas. And then I'd like to thank many of my colleagues from the Department of Family Medicine, and in particular Val Gilchrist and Sandy Kabnetz, who were instrumental in getting this project off the ground. So whether you agree or disagree with the premise or the implementation of the Affordable Care Act, I think one thing that is clear from the implementation of the ACA is that we are in a time of transition in healthcare, that we are in a state of flux that is a result of patients who were previously uninsured now having access to healthcare, and the ACA mandate to deliver high-value, cost-effective care. So we have two sort of countervailing forces here. We have more patients coming into the system, and we have an initiative to provide high-value, cost-effective care to those new incoming patients as well as our existing patients. The ACA calls for, in part, improving healthcare by reducing inefficiencies and waste in the healthcare delivery system. Those of you who are familiar with Dr. Carrion's work will recognize the SEIPS model. I think one of the tenets that I want to focus on here is thinking about the healthcare system as a system of interactions, as a system of components where the pieces themselves are interactions. And one of the things that we want to be particularly cognizant of is the interactions between the parts of the system. And one of the key contributions of the SEIPS model is the idea of measuring what are those interactions, what are the connections between the different facets of the system, and tying those to outcomes. In the original SEIPS model, the person in the center there, the individual, either the patient or the individual healthcare worker, is generally described as a single individual. In the 2.0 model of Rich Holden's, which came out in 2013, that's expanded to include the concept of groups of individuals, to talk about teams. And that's one of the areas that I'm particularly interested in, is how do those groups of individuals, how do the interactions among the people in the center of this picture impact the downstream effects on processes and outcomes of care. But one of the things that we don't or haven't had a clear handle on is what is the clinical significance of the teams and the teamwork. So there's a general sense that teamwork is important, that coordination of care is going to lead to better patient outcomes, but it's not something that's very easily measured. And so hopefully my work will illuminate a little bit of that picture, but there's still a lot to be done. There is so much going on in terms of interactions and teamwork and teams working together and coordinating, that getting a clear handle on what that effect is going to be, in particular for patient outcomes, is something that has been very much up in the air. So let me start with a couple of definitions. So as I'm thinking about teams, I'm using a fairly restrictive definition at the moment. So I'm thinking of teams as the unit of individuals within the clinic that are caring for a specific patient population. Obviously, the team itself, as we think about patient care, is also going to go beyond the walls of the clinic. But for the purpose of this particular study, I'm thinking of within the clinic walls. So within the particular clinic, who are the individuals that are interacting together to provide care for a particular panel? And as we think about teams, team members coordinate either in a directed fashion or in an ad hoc fashion their actions to create long-term outcomes. So there will be coordination. It will occur. The question is often going to be whether that is something that is pre-planned, whether that's something that's directed, or whether that's something that is occurring essentially without a prevailing set of conditions or circumstances laid out for that interaction to occur. It is going to happen. But is it designed into the system for that interaction to take place and for it to be coordinated? But teams are not just simply groups of individuals. The teamwork itself relies on the interdependency among the individuals. So just as in an engine, a set of gears operating, they may all look like they're operating efficiently or operating well if there is if there's a difference in the speed or in the rotation, there's going to be friction. So the pieces themselves need to work together. They need to fit together in order for things to move smoothly. So if there is a difference in terms of the way in which individuals themselves are operating, and that function is not coordinated together, then we're going to be bringing inefficiency and friction into the system. So this is the model, a stripped down model from the larger SEIPS model that I'm going to be testing in my particular study that I'm going to be talking about in a little bit. What I want to be looking at are the structure of the teams themselves. What are their sets of networks and coordination and interaction? Can I put a handle on how well the team itself is connected and how well the team itself is facilitating each other's work? Can I then tie that into some processes about the team? And in teamwork literature, we often talk about things like shared knowledge, so the team itself being aware of what it as a whole is doing. About team awareness, so being aware of each other's skills and actions throughout the course of the working day. And team climate, whether the team itself is built to support each other or whether the team itself is operating as a set of individuals who themselves are not, may not necessarily be functioning as a unit. So I'm going to go into more detail into some of these structure and process facets in a little bit. As I think about where this leads to, the outcomes here are not simply that of the patient. They are also the outcomes of the team and the individuals within the team. The job satisfaction, the burnout, the turnover within the team that itself could have a direct effect on patient outcomes. So if the individual members are feeling or experiencing signs of burnout, that itself could have a direct impact on what's happening in terms of patient care and patient outcomes. And then in terms of patient outcomes, for this particular study, I'm looking at a variety of different indicators of quality of care and cost. So I'm going to be talking about a study that evaluated outcomes for patients with cardiovascular disease. And I will look at some indicators of cardiovascular disease outcomes, things like LDL control and blood pressure control, but also try to link this downstream to some of the larger impact events, things like patients ending up in the emergency room, urgent care centers, hospitals, and the overriding cost of that type of care. So, I'm a social network analyst, so I deal with developing pictures and diagrams of systems of interaction. And so one of the first things that we as social analysts have to decide is how are we going to define a link between two people in our system. And in this particular study, I collect data on a variety of different ways in which people are interacting. I'm going to be talking about a couple of these. I'm not going to cover all of these. There's still some future work to be done looking at some of the different ways in which we have connections between individuals in the clinic. But the main things I'm looking at are patterns, so patterns within a system or a team of individuals of things like friendship, advice, communication, and support. And so I'm going to define a connection between two individuals if there is this type of interaction within the system. I talked about relational coordination. Relational coordination is the way in which the team itself defines its interactions and itself lays out the way it is going to accomplish its goals. And in order to do that effectively, there needs to be frequent and accurate communication within the team so that everyone is aware of what the team is doing, when, why, and how. More sort of technically speaking, the way in which teams function is through things like shared knowledge. So individuals having a sense of who knows what, who's going where, who is responsible for the different aspects of the team's functioning. And without communication, without interaction, without the connections between individuals, it's my premise that that shared knowledge is going to suffer. That the awareness of others' skills and actions is going to suffer if there is not coordination within the team. Besides simply having knowledge, there's also a need for an awareness. So it's knowledge of who has responsibility for what, who has which skills, where are those going to be applied, but it's also being aware of the rest of the team's actions in coordinating that whole system of interactions. So the team itself needs adaptability, and particularly in primary care, needs a great deal of adaptability, needs a great deal of situational awareness. Primary care itself deals with such a wide spectrum of potential needs and stresses on the system that without that sense of each other and where the team itself is adaptable and where the resources and the actions of individuals can be best utilized, the team itself is unlikely to be functioning at peak efficiency. Again, coordination, communication, I see as one of the keys to the team itself being aware and functioning in an optimal fashion. There have been a number of studies that have tried to put tried to get a handle on some of these issues in terms of relational coordination. The ones that I've seen typically are things like surveys of the clinicians in a clinic about how well they feel the team itself is functioning, how well they feel that the pieces are fitting together. And then typically things like patient surveys that ask the patients about efficiency of care and optimal care and how well they think that the team itself is working. So there has been some research looking at relational coordination, and in particular, there have been some studies looking at things like post-operative pain in knee and hip replacement that suggest that better relational coordination is actually directly linked to some better patient outcomes. So less pain, shorter recovery times, that if the patients feel like the team is working better, and if the clinicians essentially agree that the team is working better, that there are some sort of hard patient outcomes that are better in that situation. But the measures of relational coordination, I think there's some issues in terms of what's driving what and actually getting a handle on how well the team is functioning. And so hopefully after you see the study that we've done, it'll give us a little better sense of some of those issues in terms of relational coordination. Okay. And then the last feature of teamwork in terms of processes and working together that I want to highlight is team climate. And this is something that I've also measured in the clinic setting. So things like shared vision. Does the team itself feel like they have a common goal that they are all working towards together? Is there a general sense of appraisals of weaknesses and strengths as a whole in the team? So task orientation. Is there safety in terms of participation? Is it safe for everyone to voice an opinion and to receive feedback in the team setting? And then support for innovation. If people have ideas for working with or adjusting the team structure and the team function, will that receive support? Will it receive an opportunity within the team setting to move forward, or at least to draw discussion and consideration? Again, the team outcomes themselves, these we measure some of these at the individual level. They're also an indication oftentimes of how the team itself as a whole is functioning. So if the individuals in the system are suffering from poor job satisfaction, if there's consistently high turnover, if there's symptoms of burnout, that may be an indication that the team itself is breaking down, that the team itself is not functioning well to support the individuals within the system. So in the human factors world, we're talking about the optimizing things both for the individuals and for the organization as a whole, because they're both important. If we get one without the other, it's not going to last long. Things are going to break down. So the question is, do communication structures matter for patient outcomes? Part of the title was about electronic communication, so we'll get into that in a little bit. But here we have a marriage counselor. What do you mean we don't communicate? I sent you an email. So I mean, there are aspects of communication that fit particular contexts, and they may or may not be appropriate for every situation. All right, so let's get to the research study that I and a number of colleagues here in the room were instrumental in putting forward and moving to publication. So there's limited evidence on how those communication structures affect quality of care outcomes, to link the actual interactions, the interactiveness of the team, to team processes, things like shared knowledge, team awareness, team climate, and then to come down the line and see where does that go in terms of patient outcomes. So the study that we did was conducted in 6 of our primary care practices here in UWMF. There were 31 teams that I identified within those 6 practices. So I'm not going to get into too much explanation of the way in which I define teams, but let me just say that the team was defined with a clinician as the focal point, and I asked people to identify who was on their care team, and if an individual indicated that they were on that clinician's care team, they were part of the team. Or if the clinician identified someone in the clinic as being part of their care team, they were part of the team. What this creates is overlapping teams. So an individual outside of a particular clinician could have been a member of 4 or 5 multiple teams in a clinic. But within each of those teams, I'm then looking at what's happening in terms of communication and interaction within the team structure. So even though there are overlapping teams, I consider each team individually. And my patient outcomes in this case are going to come from cardiovascular disease. This idea, this concept, doesn't particularly restrict itself to cardiovascular disease patients. I mean, it could be applicable to essentially any patient that's walking through the door, but with cardiovascular disease, it's one of the things that's a little bit easier to get a handle on with things like electronic health records, to get an idea about what's happening in terms of patient outcomes. So for convenience sake, I'm going to be talking about cardiovascular disease here, but we shouldn't be restricting ourselves to a particular patient panel in this case, I think. I mean, what we're talking about could be applicable to virtually any of the situations that a primary care team is experiencing. All right. So hypertension and other forms of cardiovascular disease are a pervasive public health problem. It's an enormously expensive condition for our healthcare system to deal with. It's estimated that more than 1/3 of primary care patients walking through the door have one or another form of cardiovascular disease. And that the total cost of care is over $270 billion a year. It's an enormous piece of our healthcare system, of our economy. The cost of care for patients with cardiovascular disease. What I want to determine in my study is whether the network structures of the teams themselves can be related to quality of care and cost outcomes. And my hypothesis going into this was that I thought we would see that face-to-face communication was something that was going to be critical in terms of patient care. And, but there's no guarantee going in that was necessarily going to be the case. There is a lot of communication taking place in the clinic that's not face-to-face. There are enormous volume of interactions that are occurring through things like the electronic health record. And there is a premise as part of the ACA that effective use of the electronic health record system may be one of the ways to create efficiency, that it may be a way to coordinate things in a more effective way. So, we have a hypothesis. We have something to test. We have to go out and see if we can tell which of these notions is the one that's going to prevail. All right. So what we did with the study was to go into primary care clinics and invite everyone in the clinic to take part in a sociometric survey. So a sociometric survey asks people to go one at a time and think about their interactions with the other people that they're working with in the clinic, and to define things like how frequently are face-to-face interactions occurring with this set of, with this person, this person, this person. How frequently is electronic communication occurring? How much support and sort of friendship things outside of the clinic setting come from different members within the team. And so I asked everyone in the clinic, the physicians, the physician assistants, nurses, the technicians, the medical assistants, the clinic managers, the receptionists. I asked the medical receptionists to take part in this as well, in part because I've talked with clinicians who say things like, well, my receptionist always seems to know that this patient needs a 45-minute visit. You know, that this is going to be one that's just not going to fit into 15 minutes. You know, and I happen to show up and it's scheduled for 45 minutes. Well, how did that occur? Well, somebody has to know what's going on. I mean, somebody had to have known beforehand that this is a patient that is going to have a variety of complex interacting issues, and that it's not going to be something that's going to fit into a typical 15-minute visit. So somehow the person that scheduled that got the message. Well, somehow someone was interacting with that person. They didn't, I presume, decide this on their own. Somehow they knew. Well, that's what I want to know is, you know, can we tell, looking at team structures, if that type of interaction is present in the clinic, and if it makes a difference for patient outcomes. So the two types of connections I'm going to be talking about today, and that I discussed in the paper that just recently came out in Annals of Family Medicine, are face-to-face and electronic communication. So like I said, I'm not going to go into some of the more broader definitions of an interaction between two people. So we have information about support, task-based support, emotional support. We have information about sort of outside clinic relationships, you know, friendships and things like that. But I'm not going to focus on that for the moment. That's hopefully something that's coming in a future iteration of the analysis. But let's start with some sort of hard and fast, you know, day-to-day functioning type connections, things like face-to-face and electronic communication. So this is the way in which I asked people to define face-to-face communication. So they were given a survey, and over here on the left where it says IDs, there were ID numbers there, and there was a list of members who were, of team members or clinic staff members, people who were working in the clinic down that side. And then when the survey was done, we tore that off and threw that away, so all that was left over was the ID numbers. But I'm asking people to define, for everyone else in the clinic, how frequently are they interacting with that particular individual face-to-face with regard to patient care. So how often is face-to-face a patient care communication taking place with everyone else in the clinic? And then I do a similar thing with electronic communication. So how often in the past 6 months do you feel like you were communicating with this particular person about patient care? And hopefully this is sort of ingrained enough in the day-to-day operation that people have a sense, you know, yeah, okay, these are the people that I walk in the door, and you know, I talk to this person, this person, this person, and I get communications by electronic health record from this person, this person, this person throughout the day. I also asked people to fill out a team climate inventory. So there is a 38-item, extremely detailed scale about team climate. I used a shortened version of this. It had 14 items, and it breaks it down into 4 different components. So the first couple have 4 questions, and the last 2 have 3, about those issues in terms of team climate and team processes, the team working together, shared vision, safety in terms of participation, task orientation, and innovation. And then to get at patient outcomes, I'm going to the electronic health record. And I'm going to look at some things like LDL and blood pressure for cardiovascular disease patients. I'm going to look at some of the high impact, high cost visits, things like urgent care, emergency hospital visits. And as a health economist, I try to attach a dollar figure to some of these outcomes as well. So I'm going to apply things like average costs for a day in the hospital or average cost of an emergency department visit to get a sense of just how big an issue this might be. All right. So my patients, I wanted to identify patients of the team. So I wanted it to be a patient that was seen by the team semi-regularly at least. So at least 2 visits in the last 3 years, at least 1 visit in the last 12 months by the lead clinician of the team. And then I used the electronic health record to filter for various cardiovascular disease ICD-9 codes. And what I come up with for these 6 clinics is a patient sample size of nearly 7,500 patients. So a fairly substantial set of patients who are regular patients of the clinicians and who have one of the cardiovascular disease diagnoses. So, social network analysis. One of the ways that we work is through visual representation of interactions and systems. So pictures of the way in which the team itself is connected. And once we get those pictures, we try to parameterize. We try to put a variable on that picture that describes something about what's going on. So one of those issues is density. It's essentially how many connections there are between the individuals in the system. We have, on the picture in the left with the red circles, a fairly sparse network, very few connections, compared to the picture on the right, the green circles, a fairly dense set of interactions where a lot of people are connecting to each other, and there are a lot of connections across the team. So density is something that I'm going to measure and evaluate in terms of outcomes. Another issue is centralization. So a network itself may be very centralized, where one person or a small number of people are sort of the hubs of communication within the team, and they sort of take in information and disperse it back out. That's the picture on the left here. Or it could be a decentralized system where individuals generally have the same sort of place in the system. There aren't a small number of individuals that are the sort of directors of communication. There's no guarantee going in that one or another of these is going to be optimal. There are systems where centralization is key, because in that case, if you want to get information to someone, you can get there in a fairly short number of steps, virtually guaranteed. You go to the person who's in the center, and you let that person know where the information needs to go, and they direct it. So in this picture on the left, you can get from any one person to another in 2 steps, always. You start on the outside, you go to the middle, and that person directs it out to where it needs to go. If you look at this picture on the right, it could potentially take you 3, 4, 5 steps, depending on where you start the information going, to get it to the person you need it to get it to. So there's no guarantee that centralization is a good or bad thing, but it is something that we can measure as we start to look at what's going on with team communication. There's some modeling, and the main point in the modeling here is that this is a hierarchical structure. So we have to take into account the fact that we have clinics, we have teams within clinics, we have patients seen by the teams. There's a sort of hierarchy that needs an analysis structure that fits that hierarchy. All right, so let's start looking at some data, some of the good stuff. So I went into 6 clinics. I invited or asked 160 people to participate in the study and got 155 to participate. So better than 96% participation. I was shocked. Yes. It was amazing. I had wonderful help from the clinics that I was in. They were incredibly facilitative and helpful in terms of getting me and my staff in and out and not disrupting what was going on in the clinic day, and getting people on board. We had, again, a wide variety of participants, from the physicians, the nurse practitioners, the medical assistants, the nurses. Everyone, generally speaking, took part. So it was really amazing help from our clinics. We start to look at some of the descriptives, things like years in the clinic. One of the things that surprised me was that nearly 20% of the people who were in the clinic had been in their particular clinic for a year or less. So there is this sort of underlying set of turnover or disruption in terms of team structures that we hopefully will be able to capture. I only have one point in time here, unfortunately, but there are future iterations of this to look at things like multiple time points and to look at the way in which turnover and sort of new members joining the team affect team structures and team outcomes. Over 2/3 of our participants were working 75% time or more. Some of the metrics in terms of the connectedness. So it's interesting, if we look at face-to-face communication, density of 0.45 means about 45% of every potential connection between two people actually occurs. So they're fairly dense networks of face-to-face interaction in the clinic. That's actually pretty good. Electronic communication, I was surprised, was considerably lower. So 0.31, just over 30% of any two potential electronic connections were occurring. And the way in which I defined connectedness here using my survey was actually a daily or more frequently. So I had a scale, and I cut it off at daily or more than one time per day as a connection. So there's possibilities in terms of looking at some weaker connections or some less frequent connections. And in one of my future papers, I do look at some of the less frequent connections and how that is related to outcomes as well. In terms of team climate, the shared vision scale, this was on a 0 to 4, 0, 1, 2, 3, 4. In general, people were rating that about a 3. So it was pretty good. Lower scores for things like participatory safety and support for innovation in terms of team climate. All right, so now the fun stuff. So I get these 31 teams in the 6 clinics, and for each of the teams, I then map out what does the connectedness within that team look like. And this is an example of one of those. So the color here is whether the person had 6 or more connections to other individuals within the team. If it's dark blue, they do. If it's a light blue, they're less connected they tend to be more in the periphery. And our physician here is sort of outside the main circle. And that's evident in virtually every one of these pictures, is that the physician is not the person in the center of the picture, that there is a team of individuals that are functioning sort of behind the scenes and then make a connection to the physician. It's not the physician in the center with the interactions occurring around the physician. This particular picture is an example of one of the more well-connected, so denser networks, as well as one that is fairly decentralized. So centralization is essentially the difference between the person who's getting the most connections and the average of everybody else. So if there's one or two people that are getting a lot of connections and a lot of people that are getting very few, you have a wide disparity, and that is an indication of high centralization. If the connectedness is generally pretty even, that's an indication of decentralization. And then this is another clinic. This is an example of a team that, generally speaking, is less connected, is sparser connections, and more centralized. So here we have essentially 4 individuals in the center of the team who are receiving and dispersing the information to the rest of the team.
What's MR?
Medical reception. Yep. So yeah, MA, the medical assistant, RN, the nurse, and MR is the medical reception. There's lab techs and radiology techs that generally are more peripheral, although that's not always the case. There was one network where radiology tech was the person.
What is CM?
Clinic manager. Yep, clinic manager. Yep. So if you wanted to look at this more closely, I have copies of the paper that just came out in Annals of Family Medicine, or you can also email me. I'll send you a PDF. You can read into it further. But you know, it's just fascinating data here. It's just great stuff. All right, so let's start talking about where things go in terms of the patient and the team outcomes. So the first thing I did, and I don't have any slides about it, the first thing I did was look at general connectedness within the team. So if there's any sort of link between individuals, whether it's face-to-face or electronic, does more connectedness seem to be tied to better patient outcomes? And I find out that it does in general, that higher density of connections is associated with fewer emergency and hospital visits, fewer urgent care visits, and better control of LDL and blood pressure. And that in general, less centralized networks were associated with better patient outcomes. So that was the first step to look at sort of overall, does there appear to be a link between density of connections and patient outcomes. But then after I did that, I wanted to break down whether it looked like it was face-to-face or electronic connectedness that was the key component. And that's what this next set of slides is about. So when I put them both in the same model, when I put face-to-face communication and electronic communication in the same model, predicting some things like patient LDL control or blood pressure control, what I'm finding is that it looks like face-to-face connectedness is a driver of better patient outcomes, that electronic connectedness is, at best, balancing the face-to-face connectedness, and at worst, a driver of less optimal patient outcomes. So the odds ratio here, 1.17 for face-to-face communication, indicates that if there's more face-to-face communication density, there's a 17% increase in the likelihood that the patient will have LDL controlled. And not significant, not statistically significant, but even a higher likelihood of blood pressure control. So 19% higher, although the variability there doesn't give us the opportunity to say statistically that face-to-face communication is linked to better blood pressure control. The electronic communication is associated with a lower likelihood of a patient having controlled LDL or blood pressure. So the more people that are involved, the more connections there are between the individuals on an electronic basis, the lower likelihood of LDL control. Now, I'm not trying to say that, that the electronic health record is the driver of this, is the cause of this. I mean, we have a link here, we have an association, but it's tough to make causal statements about electronic health records damage patient health. But in terms of putting the two pictures together, at least from the data that we have, electronic communication in the absence of a strong face-to-face network could be associated with worse patient outcomes. Start to look at some things like urgent care visits and emergency department visits, and now we're starting to get some fairly dramatic results. So an odds ratio of 0.34 in terms of urgent care visits means a 66% reduction in rate of urgent care visits if there's an increase in face-to-face communication, if there's more people involved in the face-to-face network. Emergency rooms, 0.28, 72% fewer emergency department visits if there is more face-to-face density within the network. So something's going on. We don't know if this is necessarily causal, but there's definitely a link between these two concepts. A link between a network, like the first one we saw, where there is a high density of face-to-face communication, and patients who do not end up being in the urgent care center or the emergency department. And similarly, I find similar results for hospitalization and for overall costs. So I see an association between better face-to-face communication density and roughly $600 less per patient per year in costs. $600 per year for cardiovascular disease patients are expensive. They're utilizing a lot of resources, but still, I mean, $600 per year is not something to be taken lightly. I mean, per patient, and 7,500 patients in 6 clinics, we're talking about an awful lot of healthcare utilization that is connected in some way to face-to-face communication. And then, so I talked about team climate and the team climate inventory. I looked at the various scales of the team climate inventory, and the one that seemed to pop out, the one that was consistently there, was shared team vision. So this is a structural equation model that suggests that face-to-face communication density is itself tied to better shared team vision. The team itself says, we have common goals, we're working towards those common goals, and that shared team vision, if a team has higher sort of global shared team vision, that's associated with fewer urgent care, emergency department, and hospital days. So a negative correlation as that moves downstream. So there does appear to be something in terms of team climate and in particular shared team vision that may be part of a link between the network of communication and the patient outcomes. I also did some qualitative interviews. And and asked people about communication in the clinic. What facilitates good communication? Where does it break down? What are the positives and negatives? What are good situations that are occurring or less than ideal? So here's one of the quotes. I think it's hard with Epic because when Epic came in, you lost that vocal communication because everything shows up as in a basket or an order, and you're looking at a monitor to wait for something. And I think it's hard to know where that patient is in their process of care of their visit. Okay. I think we communicate so much through the electronic medical record that we forget to be human and interact that way. And someone else said, well, people get so overwhelmed with all the emails that they blow by them. They don't read them, and that communication, important information, is lost. Okay. So just to get a sense of the feeling from some of the teams in the clinic that there really is something, there is something going on. We need to delve in more deeply and figure out exactly what that is, but there is a sense that there is something about electronic versus face-to-face communication that is critical for delivering optimal patient care. So, do communication structures matter for patient outcomes? Well, I don't think we can definitively say that yet, but we have some evidence pointing that way. That face-to-face communication at least is linked in a cross-sectional sense to better patient outcomes. That there may be something going on that we can get a handle on and potentially address. And in our primary care teams, where there is more interaction, we see that we do have more effectively controlled LDL cholesterol, fewer emergency and urgent care visits, and lower healthcare costs. So, a takeaway, and then I'll open it up for questions and discussion. Communication networks, I think, can provide a framework for the redesign that we're talking about, this notion of delivering high-value, cost-effective care, that effective face-to-face communication may be essential for delivering that high-quality care at the lowest possible cost in our primary care settings. Okay, thank you. I will